Also the new.
All right, we're good. We're live. So this afternoon's Night Spots discussion will focus on Creepshow. So where would the group like to start?
Should we just start from the first story?
Wherever you want.
I think that makes the most logical sense.
Or like what is tying these stories together? Like, would that help us figure out where to start?
Well, I want to know what tied it to Seinfeld.
I'm trying to find the connection.
Yeah.
It's the same answer, by the way.
No, there we go.
What ties the stories together ties it to the abstinence. But I'm not going to disclose that, much less in the first minute.
Oh, man.
Let's see if we can work through this. So what, any particular character, and if you're going to go with Father's Day, which is perfectly fine, which is another reason why we chose this movie this week. What characters intrigue you?
Well, I thought the dad was kind of interesting.
Oh, yeah.
I don't know. I kind of, so the way this is what I was thinking. So like Seinfeld for me, like, and the show altogether is kind of like a dark humor in my opinion. Like it's like you laugh at things that you shouldn't laugh at, I guess. And that scene, I guess, kind of like the serving of the birthday cake at the very end is kind of like my connection to it. It's like that's kind of like not funny, but like it's like dark humor in my opinion. So that was the connection that I made, but I didn't really, I don't know. I'm also not a good movie critic, so in my novice, that's what I thought of it. But
Well, yeah, I mean, I think I agree in terms of just the different things, like there's several things going on, but there's some sort of progression from humor to like intensely not humorous, and like that makes it more striking sort of when these things come about. So I guess, you know, also in the case of Seinfeld, in the case of sort of a lot of these things that we've seen, like you kind of have things that are presented as like funny, like everything that's going on with George, but then it's like kind of like not really funny, like it's kind of like it really impeding is functioning, but it is funny, it's a comedy.
Mhm.
And then with the horror stories, it's like I think the most striking example of this was the one with the grass and the growth and like the planet, I don't know what it was called, but it was really comical. At least I found it very comical, and then all of a sudden it was the most like not comical sort of ending that I could imagine. So that may be one theme, and just kind of like I guess the perception of like normalization of all of this. But the reality is that it's not normal and that it's very serious or can become very serious.
So with your reference, if Jordy, the character from the short that you refer to, were to present to clinical practice during your psychiatry clerkship, and in providing you his HPI, which then would be the plot of his film short, what comes to mind? I mean, now you have to call your attending, and your attending is always going to put you on the spot and say, what do you think is going on? So what do you think is going on? Because one of the things, I'm sorry to cut you off, one of the things I'm going to actually give you a little bit of a hint here on where to go, is that I would hope that if you're rotating on my service, you are not going to tell me that he had an alien encounter. Right? So this is one way in which we kind of sidestep this idea. Well, is it supernatural or is it psychiatric? We're here for at least the next 4+ weeks of your life to get prepared for a psychiatry shelf exam. So from that perspective, now you're on.
I kind of interpret it as like a very hallucinatory and like delusional episode where I mean he finds this meteor or whatever and believes it's going to be this, you know, answer to the debt that he's in, and just kind of really believes this, he takes action for it. But then also with like the grass growing and just kind of seeing like this blue liquid from the meteor little cracks, like that kind of reminds me more of like either illusion or hallucination overall, depending on like what the real situation is.
anything in this tale that would support your working diagnosis when it comes to what would predispose an individual to have a psychotic break?
It seems like he lives alone and he's isolated,
Under significant stress.
under stress.
Mhm.
I'm not like sure how we would judge his baseline function, but he seems to not be the most intelligent person. And maybe he's like susceptible to,
Cognitive deficit.
Yeah.
Talk to me about your initial observation of him living alone.
his house was pretty disheveled, and gross. He didn't seem super, he wasn't well kept. He was on a fairly big plot of land, and didn't seem like there was anybody around him.
And which you, not to over pathologize this character, but if he's presenting to clinical practice, you've got to consider a differential here. What might be in your differential at this point with those observations?
Maybe a personality disorder.
Which one?
Schizotypal.
Schizoid versus schizotypal. Certainly his being both physically and especially emotionally distanced
Mhm.
from others is consistent with the schizoid personality. Now, if he, upon a diagnostic interview, offered you that he very much would prefer to be around people, but feels too socially inept to interact, we may need to consider avoidant personality disorder. However, my gut says upon questioning, he is likely to say that he is perfectly content living in his current situation, which would reinforce and support the idea of a schizoid personality type. Schizoid personality, as well as the other cluster A personalities, we mentioned one, schizotypal. What's the other? Paranoid personality. All do confer a risk of not only future mental illness, but more specifically, future psychotic illness. So there are elements to this story that certainly support the idea that he is predisposed to a psychotic break. And that includes schizophrenia as well as other psychotic disorders. So I heard the word delusion, right? Delusion may be the defining characteristic in a delusional disorder. It also might be part of a larger illness called schizophrenia or even schizoaffective disorder. Given the nature of cognitive deficits, it's suggestive that it's probably schizophrenia, but we would certainly need more information.
He also has some of this, like self-deprecating and kind of like a splitting, he has these fantasies of, sort of being rewarded and well compensated and sort of, liked because he found something and then he sort of imagines, sort of this very extreme version that he like broke this meteor and then all of a sudden it's the opposite where he kind of, then really failed and did something really terrible. It was interesting.
Kind of another thing I picked up on maybe was maybe this like delusion of reference, where it seems like the radio or the TV is sometimes kind of like saying something that kind of fits his narrative, and it seems like he's maybe internalizing that to his situation.
Yeah, the delusional or delusion of reference, idea of reference, delusional misidentification syndrome, all explain the same thing. These terms are interchangeable, where there's a two-part process where an individual senses, that is, sees, hears, or otherwise, a real environmental stimulus that any one of us, God bless you, would attest to, but then imparts a delusional meaning to it. Right. So, and that's exactly what happens here. Right. So, yeah, so there do appear to be ideas of reference too. That would again more support schizoaffective versus schizophrenia than delusional disorder. In either case, there are 5 different themes of delusion. Now, if this were part of delusional disorder, we would call these the 5 subtypes of the disorder. If not, and that might be in fact in this case, we'll just refer to them as 5 different themes of delusion. What are those 5 themes, and which one do you think is on display in this particular subplot? That's one. Same thing. Yes, thing. Good. Good.
Matter?
One more to go. That's a type of delusion, but not a theme. Yeah, the final theme is jealous type or jealousy. The acronym is JPEGs. But you got them all. Right? Yeah. Jealous, persecutory, erotomanic, grandiose, and somatic. Which one does Geordie demonstrate?
I don't think grandiose at first because he like thought that he would like have this huge discovery and have all this like problems go well.
But his second one, so should like they were gonna reject, like the Department of Need. was gonna
That's true,
reject it,
yeah.
right, because of
So-
growth, right, so.
He's physically like turning green, so somatic.
It's somatic, yeah. Yeah, there are different forms of somatic delusion. One is halitosis, the delusional belief that you're giving off some odor. Dysmorphia, a part of you is misshapen in some way. And then the final one is infestation, which is what we have here. Right, now infestation, we usually think of bugs, the other name, when bugs. We also refer to it as delusional parasitosis. But in this case, it's still infestation. Yes, it was. Yeah. So Geordie does appear to be struggling with somatic delusions, probably in the context of a larger condition to which he was predisposed, given evidence of schizoid personality disorder. Anything else for this character? When you were asked a shell question about the cluster A personalities, and the American Psychiatric Association is actually in the process of moving them out of the personality disorder chapter and into the schizophrenia spectrum, another psychotic disorder chapter of the DSM, which is nice because the personality disorders are sometimes somewhat difficult to learn, especially and remember for exams like the shelf. And if that were to happen, that is, if you looked at these as prodromal to schizophrenia, for example, it only leaves you with 7 personality disorders then to have to study. Right? In each case, that is the paranoid, schizoid, and schizotypal, these 3 conditions, call them prodromes, call them personality disorders, doesn't matter, are all hallmarked by a cardinal feature, meaning that when you study them in your favorite board review text, all you need to do is remember that cardinal feature, because when you look at the diagnostic criteria, then they morph, pardon the pun, Jordy, they morph into examples of that cardinal feature, and they'll be processed much less as diagnostic criteria that therefore you have to memorize, right? Paranoid personality disorder, cardinal feature, pervasive distrust, pervasive suspiciousness of others, right? And then if you look at the criteria, of which I believe you need 4, nothing but examples of that cardinal feature. Schizoid, individual who is emotionally as well as physically distant from other interpersonal interaction. And while that is also somewhat true for the schizotypal, the individual with this condition has a level of bizarreness and eccentricity that really define who they are. Right, so those are the 3 cardinal features. Again, remember them. Now, when you study, it's probably going to be a lot easier to identify the actual diagnostic criteria and those different points that will make that clinical vignette. Questions about cluster A personality disorders, their role in posing risk for future psychotic illness, or the case of Jordan. No. By the way, before we diagnose perhaps schizophrenia, as this appears to be a working diagnosis, the clinician must appreciate that this condition is a diagnosis of exclusion, right? So as a diagnosis of exclusion, what are the different things now you are going to think to investigate and rule out before we support this provisional diagnosis? There are 5 answers here.
Medical.
Good. Psychosis due to an underlying medical condition,
The substance.
due to the direct and physiological effects of a substance. One, I'll cheat, I already gave to you, schizoaffective disorder. Right? You heard me flip-flop back and forth, either or, well, schizoaffective takes precedent. 2 more.
Other group or psychotic disorder.
That's going to be in a differential, but not necessarily required to rule out. primary mood disorder. That's either major depression, bipolar disorder. Up to 50% of individuals with bipolar will experience psychotic features in their lifetime. So that has to be investigated, as does a depressive disorder. And then finally, an autism spectrum disorder. So looking for that pre-existing condition. Those are the 5 that you rule out. Now, for substances, we have to consider that not every substance can induce every mental disorder. We kind of referenced this, or at least introduced this idea earlier today when we talked about the tobacco-induced disorders, and that withdrawal was the only tobacco-induced disorder that is recognized by the American Psychiatric Association in the DSM. What are the 5 substances that can induce, well, 5+ substances that can induce psychosis?
Alcohol withdrawal.
Alcohol, good.
Steroids.
Yes, but not listed as a substance of abuse per the DSM, but it certainly is. I'm going to give you that one. Stimulants, yes.
So what about like the marijuana, like long-term use of that?
Yeah, cannabis, yes, cannabis, yes. There is such thing as cannabis-induced psychotic disorder. Yeah.
Psychogenics, like LSD.
Hallucinogens, good. And one more, I think we're missing. Inhalants. Okay. Those are your 5. Now, I say 5+ because benzodiazepines can do it too. But it's always easy to remember benzos because anything alcohol can do, benzos can do as well. The only exception to that rule is inducing anxiety, where alcohol does, but benzos do not. That's the only time you'll see a mismatch between alcohol and alcohol in pill form, aka benzodiazepine.
Are we talking about, like, intoxication with these things, or are we talking about withdrawal of these things?
Well, it can happen in either or both. Yeah, happen either or both. But we're not talking about alcohol, for instance, alcohol withdrawal per se, or withdrawal per se. We're just saying that in either situation, it could actually induce the actual mental disorder, right? Not the feeling within the context of an acute withdrawal syndrome. That make sense? Yeah, that's actual disorder. This film short is actually based on a Stephen King short story titled, where are my Stephen King fans? None, really? Heartbroken. It's Friday, man. All right, well, I will give you that the short story is actually titled Weeds, which really does make this a nice metaphorical substance-induced, cannabis-induced psychotic disorder. That would be high in my differential for no reason other than the short story on which it's based. Where else do you want to go here? What's the next tale you want to tackle?
I thought the Tide one was stuck out. Or it was different than the other ones. It lacked that like supernatural kind of absurd.
Did you watch it at the end?
Yeah, wait, they like, did they come back as zombies?
Yeah.
Oh, God, oh my gosh. No, I didn't know
Listen,
that.
maybe that stuff's normal to some.
I was thinking more so like, there was like, no, I was thinking more of like the guy drowned. I did remember that the zombies came back.
But I think there's something you was like that, because it was like that part was so intense, like it's like a 1982 movie with like none of these special effects, and it was like just like so horrifying and intense that like I also almost forgot that other part happened, because that was just kind of like a sillier thing.
Yeah, it seems like
But,
it was, yeah, it was less of like a theme throughout the entire episode.
could have been better acted.
Without saying antisocial personality disorder, what do we think's going on here?
Homicidal ideation.
Yes, fair.
Someone who derives pleasure from watching people suffer and die.
Now, if it was sexually gratifying, sadism disorder. Right. I'm not so sure it is though, but sadistic nonetheless. What if, I mean, was there at any point during this short where you actually questioned the main character's knowledge base? How accurate he was? Despite his accusations? Right? If so, only because it gives us a chance to further discuss this.
What about also like narcissistic personality? Because he was saying like he was taking stuff that was his, was the whole like, that's part of the like, part of the issues. Like, wasn't even that mad about the actual affair itself. It's more like-
She's his property.
Right.
Yeah, so the narcissist does, that is, the disorder does follow that cardinal feature of feeling one as special and that they can only be understood by someone as special as they are.
And then they react like sometimes aggressively or violently if like they're like if that is like questioned or
Otherwise referred to as narcissistic injury. If we actually got collateral information that there was no affair going on, and we then presented that information back to the main character who's actually coming to us to seek help, and he remained rigid in his belief, what would we actually determine what's going on here? Yeah, there's a definition of delusion, right?
Maybe jealousy.
That's my next question, right? So now we have jealous subtype taken care of, right? Now, the other part of this too, and it's a reminder to clinicians, is that no matter what your initial impression is of the likelihood of the accusation, the patient's self-report, you must always investigate how reality-based it is. Okay. We've been in situations in which there have been individuals who are delirious and accusatory about people trying to kill them, and we found out that in fact that has been the case. So always investigate. All right, what else is going on in this particular short? Anything else you want to? All right, next film short.
we can talk about the first one. Yeah.
No, yeah, you started with it.
Started with it.
You guys quickly punted it.
It could be like, can you become psychotic because of or delusional because of extreme guilt, like the daughter went to the grave and she was drunk, and then she imagines that she imagines that the father like
Oh,
comes
yeah.
out, right, takes revenge on her.
Have you ever seen The Mechanic?
The movie.
Nonetheless, the answer is yes. Yeah. But, excuse me. That process is often referred to as stress-induced psychosis, right? So we have to think of a psychotic break as on a stress diathesis, right? So everybody in here comes in with a particular predisposition that is biopsychosocial predisposing factors that put us at risk for developing psychosis, right? And let's just say, for example, we're going to pick on one person, and we did an in-depth assessment and found out that that risk is 0. Okay. We can actually, at least theoretically, conjure up a degree of stress that will result in a psychotic break nonetheless. Right. And if we were to arbitrarily rate that level of stress, we would say it's a 10. We could also see that for another individual who may come in with a predisposing element of a 4, how it would require less stress to reach that same threshold, right? That's the stress diathesis. All right. Any movie here come to mind? See, I'm learning. I'm not actually saying the movie that I want you to say yes to. I'm actually now open-ended questions. See, Dr. Terragino taught me well, and I'm hoping that somebody picks up on this. Open-ended question. What do you got?
Oh, what's the one with Tom Hanks and Wilson? What's that?
Yeah,
Castaway.
Castaway.
Yeah.
Yeah, it's a good one. Yeah. All right. You want to describe it?
Well, like for Shutter Island count? It's like such
Yes.
it's like right, so you watch it again and the things that you thought were there weren't there, right?
Yeah, I mean, again, Teddy's character theoretically can have that quotient at a 0, but when he came home from work that one day, that level of stress and recognizing and processing what your wife did to your daughters can absolutely result in a psychotic break.
Ooh, or Fight Club, there we go. Fight Club, yeah, because he's like,
Well, be careful, the spoilers.
okay, all right.
Anybody here not see Fight Club?
Yes.
Okay,
Okay,
so
all
anybody here
My
not?
fault, not yours.
Oh, I'm definitely blaming you.
Oh,
Yeah.
yeah.
Anybody here not see Fight Club and not know the end?
I saw that.
You guys have been able to actually escape a decade plus without ever.
I thought we were like
Yeah, we can.
20 years old at this point.
99.
Yeah.
Yeah.
Oh, yeah, I mean, can't talk about it. Yeah, they somehow never found out the ending, just in case they want to watch.
Right?
it.
By the way, watch Fight Club.
Yeah.
Yeah, but before somebody that despises you tells you the ending.
Got it.
All right, the movie I was thinking of is Donnie Darko.
It is what?
Donnie Darko,
I was really close years ago. It was very confusing.
yes. Yeah. I won't get into details about it, but the general idea is that we're talking about a stress diathesis model here. All right, what else is going on here? So, is it? I'm actually forgetting her name. Is it Bedelia? Yeah, Bedelia's Bedelia. Okay. All right, so we're thinking that this might be a product of guilt. Oh, by the way, another character is the Phantom of the Opera, Christine Daae. And the death of her father has a psychotic break plus of guilt. And I'll give you another one, Pamela Voorhees.
Okay.
Yeah, and if you're gonna ask me who she is, just leave. Just don't.
Saw it in people's eyes.
Yeah, Don, me too. That's why I said it real quick. We're not gonna go there. All right, what else is going on in Father's Day? I thought the initial comment was the patriarch. What do you think of him? Other than the fact that somebody liked his humor.
I'd like to see my. Dark humor. I mean, it's a history of like trauma as a child, I guess.
Yeah.
So
Yeah.
in some ways, like I don't know. I'm trying to think how to connect to psychiatry, but
I think that's fairly clear here, right?
Yeah.
And this is a trope. We've seen this in multiple other, I mean, I could date you back to like original Twilight Zone episodes where this is a common theme, right? Where you have the grandiose patriarch, the narcissistic, self-absorbed patriarch, and that dynamic results in developmental delay in the family unit as well as individuals within that family. So I think, one of the things in the differential diagnosis of this one character that we know very little about would be, once again, perhaps a delusional disorder here, a grandiose type. Now there's other in the differential, it's a widened differential for grandiosity. What else comes to mind?
So sort of like frustration that he's not able to care for himself. That's kind of like a reactionary, aggressive, abusive type of, type like that. I don't know. Yeah.
like a displacement almost.
Yes, that's a better word.
Yeah. And if that were to really define who he is, what personality disorder is what you just described thought to be the etiology? Is that narcissistic?
Yeah.
Yeah.
He's like everybody's sister. Yeah.
The other thing about grandiosity, or in terms of differential, we'd consider antisocial personality. And then the other one I think that's on what was formerly known as Axis 1 would be a manic episode, and therefore a bipolar spectrum, almost like bipolar 1 disorder, right? Especially if the grandiosity came in discrete episodes. On average, how long is an episode of mania? 3 months. 3 months. All right. Again, I mean, there's so little about that here. Despite the likelihood of his demonstrating clinically significant grandiosity, that differential is going to remain broad because we don't have any further information.
Similar elements of like Godfather figure in that kind of first story. So like the real first story where like you had the parents and then the child. So I initially thought there might be some sort of themes throughout Creepshow like that, because it was these like dysfunctional family and that's where the fathers were similar, but then it just became a little bit more intense.
Yeah.
So like I was trying to compare these two figures. So like that father also definitely had some narcissistic tendencies and abusive tendencies to his family, but then in a different way.
We have 2 more here, right?
More.
Stories?
Oh, yeah, the great one.
Great. So
I wasn't a fan of the phrase so much. Like it, truthfully. I found the wife to be so irritating, which I think is the point.
Why was she irritating?
She's just like loud and drunk, I assume, most of the time, and
Do you think she might be irritable due to a mental disorder?
possible, maybe alcohol use
Yeah.
disorder.
Yeah, I think she is.
She was drinking milk for the later part of the episode, so I'm not sure.
Could have been a White Russian. Could
What?
have been a White Russian.
That's true.
Yeah, so I mean, alcohol use disorder, certainly would be in a differential here. Obviously, I think the one thing, and, you know, we talked about from a little bit of a different perspective, that when we're contemplating a mental disorder, that includes personality disorder, that we first have to investigate the role substances play as well as underlying medical conditions. Well, in the same respect, in this case, if she were to become sober, if she were to become abstinent and work a recovery program, our clinical evaluation would investigate whether we continue to observe those behaviors, because if the answer is no, guess what? Then this was all attributable to the direct and physiological effect of that substance. So probably alcohol use disorder. Now, you know, there's a little bit of a dialogue here that I found very, very interesting when she actually verbally goes after her husband, and she alludes to some of the students. And there's a backstory about there maybe being erotomania, that there's some thoughts that there is a relationship there when there isn't, and he's being like now like insulted over that. Now, I don't know enough about this particular character or the character that he may or may not have had an affair with as having erotomania, that is delusional disorder of automatic type, but there's certainly an allusion to that. And whether it's on Reddit or YouTube, we could figure out that backstory. We'd need a lot more information, but if hypothetically sober and in that appointment with us, that collateral information would certainly lend to our, as a clinician, inquiring about such a interpretation. That is there a level of erotomania here? The delusional belief that someone is in love with you. And if that's the case, we have yet another theme here of delusion. Despite the fact that I really don't feel the character per se rules in for a psychotic disorder, but any other thoughts about any of the characters in the crate? The other thing I want to briefly talk about, it's a little esoteric, but there's a teaching point to this, and that is many people, especially with psychotic illness, about between 80 and 90% will smoke cigarettes. And that's a major form of mortality and morbidity for people with especially chronic mental illness like schizophrenia. Individuals with this condition, schizophrenia, have a life expectancy of about 52 years of age. It's 54 years for females with schizophrenia. And the reason why there's that shortened lifespan is due to all-cause mortality, not suicide. And they have a 5 times of the risk of dying from a cardiac complication than the general population. So one of the things that we try to impress upon individuals with this illness is to make sure that their lifestyle changes be healthy, and that includes aggressively focusing on smoking and other types of maladaptive behaviors, right? In sedentary lifestyle, and it's very, very problematic. 52 years of age. One of the things that in general we hear, not necessarily for schizophrenia, but for individuals who do go into a rehab, whether it's IOP, whether it's an inpatient rehab, to quit drinking, right, become abstinent and live sober, is addressing their co-occurring nicotine addiction and tobacco addiction. And 9 times out of 10, the response back is, "Doc, you have to allow me one vice," or, "I'm here to focus on my alcohol. I need my cigarette breaks," right? What is the reply back, whether the individual has schizophrenia, no schizophrenia, or other, and that individual who during recovery from alcohol is continuing to smoke?
You're asking like why you discuss pizza, why that's not a good idea.
Yeah, what is a point that you want to make with that patient within psychoeducation?
So the transference of one sort of addictive behavior into another, so it's not, it's sort of showing that the underlying psychology behind the addiction has not been addressed adequately if these behaviors aren't caused.
Anything else?
It's just replacing one unhealthy behavior with another.
That's
unhealthy
definite,
behavior.
yeah. And more people die from
Yeah.
tobacco use than alcohol use. Yeah, the thing that you want to make sure you get across to your patient is that the quit time for the cigarettes is now because of cross reactivity with the alcohol, with the receptors for alcohol and tobacco. Right. Matter of fact, if they don't quit, and I don't know how to say this in a healthy way, but you are going to advise them not to quit for at least 6 months. Because what can happen is that if they get discharged from their rehabilitation, from their alcohol rehab, hospitalization, and they attempt quitting cigarettes within 6 months, they are going to crave alcohol. And they're much more likely. That's studies coming out of the Mayo Clinic. So the optimal time under supervision, 24-hour supervision, where we can provide you medication to assist you through this process is now. And if not now, then don't even try it for at least 6 months because of the increased risk of relapsing for alcohol, not nicotine.
Does that apply to the reverse? Like if someone wants to stop smoking, they should also,
Not to my knowledge. No, I don't know why.
because drinking.
Yeah. Now, does Delia drink, smoke here? Is she smoking in this? I don't recall. And so something to keep in the back of your mind though, that cross receptor activity. All right, we have one more here. Yep.
Yeah, I was gonna be able to get that one.
Lots of insect things today.
A little bit of the, what's the one where you think that you're infested with bugs?
Yeah, somatic type of delusion,
Yeah.
yeah. Yeah,
Use a meat or not a meat, like a germaphobe or an insectophobe, and
it's definitely OCD, yep. Very obsessive. Intrusive thoughts. He probably does have a working diagnosis of obsessive compulsive disorder. And may even have a diagnosis of delusional disorder, somatic type. Although interestingly, this one might be a better fit for mixed type because there might be two in play, because there's a level of persecution here too. But again, we have another theme of delusion in play here. What's the difference between obsessive and before I ask this question, you're not allowed to, in your answer, use the word dystonic or syntonic. The difference between obsessive compulsive disorder and obsessive compulsive personality? No, you cannot, no, because your predecessors have tried that too, no.
Well, a personality disorder is like pervasive across your whole life or like a longer period of time than, just like obsessive compulsive disorder. Also, obsessive compulsive personality disorder is, I'm trying to do it without like. Oh, also like OCD. I mean, I guess they can both be like debilitating or like affect life. But I feel like you can have OCPD and it can like work for you.
Obsessive compulsive traits can work for you, but as soon as you begin to have and experience clinically significant distress or impairment, then we're going to put the word disorder on that, and that's when that line has been crossed. So by definition, no.
That's it.
So if somebody presents with obsessive compulsive disorder and they're sitting here right now, what are they likely to tell you is the reason why they're coming to see you?
Like more specific obsession versus like personality disorder.
Don't tell me what they're not. Tell me what they are. You said obsessions, right?
Yeah, the fixed
Right.
obsession.
So it's likely, it's very specific, so it's, she's being able to convey to you her intrusive thoughts.
I have a question, actually. So I know that a lot of times, or maybe all the time, compulsions relieve the kind of distress of like having this obsession. In OC, like obsessive compulsive personality disorder, is there a similar type of thing you can do to relieve the stress of your thought?
So let me answer that with a question first, to further clarify. And we have our second patient here who presents because she wants help for obsessive compulsive personality. What is she going to relate to you? What's her chief complaint? Could be.
Maybe she's like, doesn't have time to do certain things with her life.
That could be.
Like she's spending too much time on certain things and not on others.
Why?
Because of what she like values.
More specific. You're right. You're circling.
I don't know what I'm circling.
I wouldn't say she's like a perfectionist.
That's it. Yeah, perfectionist, perfectionism, order, control. It's type A personality, right?
Is it always that, like perfectionism for us? Okay.
Subjective degree of self-awareness.
That could be part of it, but the bottom line is that they're very different diagnostic criteria. If you ever have to remember what the diagnostic criteria is for the anxiety disorder, just look at the label. It's literally in there. Obsessive compulsive disorder is defined by the DSM by obsessions and or compulsions, period. Obsessions and compulsions are nowhere in the definition of obsessive compulsive personality.
Why do
Micromat,
we call it that then?
that's my next question. You're not allowed to pimp, you can't pimp me. I'm pimpable. This is coming right back to you. Perfectionism, miserly and frugal, detail oriented. Everything that we would really attribute to the type A personality, those two terms are interchangeable. Right? So, other than confusing medical students, which is a bonus, why would we ever think to name these disorders? Because there is overlap too, it's high comorbidity. So that is true. But why is the high comorbidity? Because that's the very reason why they were named similarly. And then the answer is common etiology. That we think that there's a common etiology because the defense mechanism, when it becomes rigid, that causes OCD, also causes OCPD. And that also accounts not only for the similar sounding name, but the high degree of comorbidity too. And that defense mechanism is isolation of affect. When an individual is made to think about something that is harmful, allows the idea to come to conscious awareness so they can discuss it, separates the affect and isolates it into the subconscious. So they're not emotionally invested in that conversation. Now, that affect cannot stay isolated. Right? And it will overwhelm your defense, which means that you're going to have to employ a secondary defense, something other than or in addition to isolation of affect. If you utilize undoing as that secondary defense, you are likely to engage in ritualistic actions. Okay, hand washing, counting. That's going to get you diagnosed with OCD. Right, so OCD is when that initial defense mechanism is paired with a secondary defense called undoing. If not undoing, but instead reaction formation, where this inner chaos is turned around to its complete 180-degree opposite, you're going to present yourself as perfectionistic. And you're going to be manifesting OCPD. So whether you have one versus the other has everything to do with which secondary defense you employ. Now, if it's neither, or if it's both, or if there's flexibility, you may not be diagnosed with anything. The diagnosis results from rigidity in defense mechanisms, and the common defense that's shared by both of these conditions is called isolation of affect.
For OCPD, is the affect that you're trying to like separate often related to the types of things that you tend to be a perfectionist about.
Dynamic
Because-
psychiatrists believe so. There really isn't scientific evidence that that's very reliable. Okay, but there are therapists that will say yes to that question.
I kind of like I don't know, it feels poetic, like internally. You have like chaos going on, but then like outwardly, everything is like perfect. I kind of think that's like really cool.
That's reaction formation. People can exert control over their environment non-verbally.
I feel like that's a little bit similar to, like the thoughts I've heard from patients I've spoken to who have like eating disorders or like anorexia and things like that. It's like in their lives, like the stressors, whatever it is in their lives, allow them to exert very little control. And so the one thing that they feel like they can control is what they eat or what they don't eat. And so, it brings them comfort to know that that's their decision and to choose to not consume food, even despite like, it's just because there's so much that you can't control in life. It's like, this is something that's always gonna be within my control.
And to your point, there are two subtypes of anorexia nervosa, binge eating and purging, and restrictive. Guess what personality disorder has the highest rate of comorbidity with the restrictive subtype of anorexia? OCPD. Yeah. So there's definitely something there.
I thought anorexia was associated with depression a lot
Oh, yeah.
also.
Oh, yeah. Just because you have one comorbidity doesn't mean you're gonna have
Oh,
multiple.
yeah, yeah.
Oh, yeah. It's also highly comorbid with post-traumatic stress too.
Mhm.
Oh, yeah, yeah. But the general idea is the cluster C personalities come into play with comorbidity for the restrictive subtype of anorexia, while the binge eating and purging subtype is more consistent with a comorbidity from the cluster B personalities.
Like, that's the histrionic borderline.
Any final thoughts? We are a quarter to the hour, so we've dedicated a decent amount to Creepshow. Final thoughts? All right, I will end with this. So, albeit somewhat guided, we really did cover every single subtype or theme of delusion and therefore delusional disorder. Jealous type, participatory, automatic, grandiose, and somatic. 5 subtypes, 5 film shorts. They match up somewhat nicely here. We could also look at each of these characters within the 5 different themes or film shorts as having an exacerbation of psychosis. One of the things that may exacerbate psychosis, and one very common thing, is the suboptimal effect of a medication, whether it's because an individual is non-adherent or whether they are adherent and are using another drug like alcohol that has rendered the medication they're taking less useful. There's also potential for drug-to-drug interactions. So when, for instance, they can be prescribed another drug, hopefully by another provider, not the same provider, but that second drug can induce the enzyme that the antipsychotic is metabolized by. And the induction of that cytochrome enzyme will result in lower blood levels, resulting in exacerbation of psychosis. For 5 characters in 5 stories in Creepshow, demonstrating the 5 themes of delusional disorder, what substance might they be using that is lowering the therapeutic blood levels of the antipsychotic that they're on? And what evidence in the movie supports that this, in fact, is the case?
Well, we said in the first, yeah, we said the first, like in Father's Day, right? She was drinking a lot, and then she goes to the grave, and that's when she sees her father, right? So that could be like you.
Could,
Like, yeah,
could,
situations like
that'd be
those.
part of it.
Is it the
It's the backup.
Ah,
the ashtray?
Yeah.
ah.
What about the ashtray?
That it was. You know, from being- I only noticed it in the first one. And then I rewatched, I think, the second one, because I didn't finish it the first time, but. I noticed it in the other ones too.
There, anybody pick up on that? That's the Easter egg that ties all this together and why we actually chose the Seinfeld episode we did this morning. Right, because of Kramer's character and the use of
Oh, the
tobacco.
smoking, okay.
There's the same ashtray in each of these five film shorts. And that was George A. Romero's idea as an Easter egg to connect the 5 plots, which is your question. And there's relevance in psychiatry, because with that ashtray, we have tobacco. And with tobacco, we have induction of the 1A2 isoenzyme. And with the induction of 1A2, we have lower therapeutic levels of the antipsychotic, and we have exacerbations of psychosis. The 5 themes of which I think are well on display in the 5 different stories that comprise Creepshow.
Is that intentional? If it goes in there on purpose, or is that just like, or does it just work really nicely?
I think Romero did the ashtray on purpose.
Yeah, but I meant like this, like,
Does he
like,
know that?
like Stephen
No,
King. or-
that's Tobia.
Okay.
No, no. So, and even I struggle with this because I mean, erotomania was tough. And I only picked up on that 1 or 2 liner that gives some impression there's a backstory to her husband may or may not having an affair. And the role of erotomania may have come in. So that's a loose association, but otherwise everything else really does fit up quite nicely. We'll end it there. We'll be back at 1 o'clock on our different link to discuss our patient case.
I told you, you